Management of Bladder Pain Syndrome, Royal College of Obstetricians and Gynecologists, British Society of Urogynecology Joint Guideline, December 2016. Definition and epidemiology. Definition for bladder pain syndrome or BPS is that proposed by the European Society for the Study of BPS or ESSIC in 2008 as pelvic pain, pressure or discomfort perceived to be related to the bladder lasting at least 6 months and accompanied by at least one other urinary symptom, for example, persistent urge to void or frequency, in the absence of other identifiable causes. The American Urological Association has described BPS or bladder pain syndrome as an unpleasant sensation, pain, pressure, and discomfort perceived to be related to the urinary bladder associated with lower urinary tract symptoms of more than 6 weeks duration in the absence of infection or other identifiable causes. BPS may be associated with negative cognitive, behavioral, sexual, or emotional consequences, as well as symptoms suggestive of sexual dysfunction, according to the European Association of Urology. BPS is a chronic condition with unknown etiology. It is seen now as a diagnosis of exclusion with no definitive diagnostic test. What initial clinical assessment should be performed? BPS is a chronic pain syndrome, and the principles of management of chronic pain should be used for the initial assessment of this condition. A thorough medical history should be taken and physical examination performed. The initial consultation is aimed at generating trust between the patient and the caregiver. Patients should be encouraged to talk about their symptoms and any theories that they have about the origins of the pain. This allows engagement in further investigations and management of their condition. It is important to explain that BPS is a chronic condition with periods of fluctuating symptom severity where symptoms may be lifelong. Symptom assessment forms the basis of the initial evaluation. The location of the pain has been described in several studies, and the most commonly reported sites are the bladder, urethra, and vagina. The location of the pain and relationship to bladder filling and emptying should be established. The description of the pain ranges from pressure and aching to a burning sensation. Voiding was found to relieve the pain in 57 to 73% of patients. Pain was aggravated by stress, 61%, sexual intercourse, 50%, constrictive clothing, 49%, acidic beverages, 54%, coffee, 51%, and spicy foods, 46%. As the diagnosis of BPS is one of exclusion, it is important to rule out other possible causes of bladder pain. The history taken should include details of previous pelvic surgery, urinary tract infections, sexually transmitted infections, bladder disease, and autoimmune disease. Other conditions commonly associated with BPS, such as irritable bowel syndrome, vulvodynia, endometriosis, fibromyalgia, chronic fatigue syndrome, and autoimmune diseases like systemic lupus erythematosus and Sjogren's syndrome. Physical examination should be aimed at ruling out bladder distension due to urinary retention, hernias, and painful trigger points on abdominal palpation. A genital examination should be performed to rule out atrophic changes, prolapse, vaginitis, and trigger point tenderness over the urethra, vestibular glands, vulvar skin, or bladder. Features of dermatosis, including vulvar or vestibular disease, should be looked for. An evaluation of the introitus and tenderness during insertion or opening of the speculum should be made. Superficial or deep vaginal tenderness and tenderness of the pelvic floor muscles should be assessed during the course of the examination. Cervical pathology should be excluded. A bimanual pelvic examination is helpful to rule out abdominal, cervical, or adnexal pathology. What baseline investigations should be performed? A bladder diary, frequency volume chart should be completed. A 3-day fluid diary with input and output is useful for initial assessment. Patient with BPS classically void small volumes, so this is useful to identify the severity of the storage symptoms. The first morning void is a useful guide to the functional capacity of the bladder. The bladder diary can also be used to reinforce behavioral strategies and, where necessary, pharmacological treatment. Estimation of residual urine volumes after an episode of micturition should be assessed using bladder scans as part of initial investigations if there are concerns about incomplete bladder emptying. A food diary may be used to identify if specific foods cause a flare-up of symptoms. A urine dipstick should be performed, and where there is a suggestion of a urinary tract infection or UTI, a culture and sensitivity test should be obtained with consideration given to testing for acid-fast bacilli where there is sterile pyuria, as this is a prerequisite for diagnosis of bladder pain syndrome. Investigations for urinary ureaplasma and chlamydia can be considered in symptomatic patients with negative urine cultures and pyuria. Other more common causes of sterile pyuria that should be considered are urinary tract stones, partially treated UTIs, and carcinoma in situ of the bladder. Ureaplasma is not isolated in routine culture tests, so would need to be specifically looked for. Investigations for urinary ureaplasma and chlamydia can be considered in symptomatic patients with negative urine cultures and pyuria. In those with a suspicion of urological malignancy, urine cytology should be tested. Cystoscopy and referral to urology should be initiated in accordance with local protocols. Diagnosis of bladder pain syndrome. Bladder pain syndrome is a diagnosis of exclusion, and other conditions should be excluded. What investigations are used to diagnose bladder pain syndrome or BPS? Bladder biopsies and hydrodistension are not recommended for the diagnosis of BPS. Cystoscopy does not confirm or exclude the diagnosis of BPS, but is required to diagnose and/or exclude other conditions that mimic bladder pain syndrome. Cystoscopy without hydrodistension is expected to be normal in the majority of patients with bladder pain syndrome. Characteristic cystoscopic findings that have been ascribed to BPS include post-distension glomerulations, reduced bladder capacity, and bleeding. Caution should be exercised as there is a recognized risk of bladder perforation and rupture associated with cystoscopy and hydrodistension. Potassium sensitivity tests, urodynamic assessment, and urinary biomarkers should not be used in the diagnosis of bladder pain syndrome. Urodynamic tests may be considered if there is coexisting BPS and overactive bladder and/or stress urinary incontinence and/or voiding dysfunction that are not responsive to treatment. How can we classify the severity of bladder pain syndrome? Clinicians should use a validated symptom score to assess baseline severity of BPS and assess response to treatment. There are 3 published BPS symptom questionnaires: the University of Wisconsin IC Scale, the O'Leary-Sant IC Symptom Index and IC Problem Index, and the Pelvic Pain and Urgency and/or Frequency Scale. The use of visual analog scales for pain should be considered to assess severity of pain in bladder pain syndrome. What is the effect of BPS on quality of life? Patients with BPS can have low self-esteem, sexual dysfunction, and reduced quality of life. Patients with BPS may have other coexistent conditions such as endometriosis and irritable bowel syndrome impacting on their quality of life. Partner and family support are important, and early referral to a clinical psychologist, patient support groups, and cognitive behavioral therapy should be considered for persistent bladder pain syndrome. Quality of life can be assessed formally using questionnaires such as the King's Health Questionnaire, Euro Quality of Life, or short form 36 Health Survey. What is the initial management? Conservative treatments. Dietary modification can be beneficial, and avoidance of caffeine, alcohol, and acidic foods and drinks should be considered. Stress management may be recommended, and regular exercise can be beneficial. Simple analgesia such as paracetamol and ibuprofen may be useful at treating the key symptom of pain in this condition. However, opioids should be used with caution as there is little evidence they are useful for long-term chronic pain. Early referral to a pain clinic should be considered for patients with refractory symptoms. There are limited data on the benefits of acupuncture. Pharmacological treatments. Oral amitriptyline or cimetidine may be considered when first-line conservative treatments have failed. Cimetidine is not licensed to treat BPS and should only be commenced by a clinician specialized to treat this condition. Adverse effects of amitriptyline include dry mouth, constipation, sedation, weight gain, and blurred vision. Intravesical treatments. If conservative and oral treatments have been unsuccessful, other therapies may be added or substituted using an individualized approach. This will depend on the experience and expertise of the clinical team involved and onward referral to a specialist center with expertise in chronic pain management and access to professionals from other specialties to provide a multidisciplinary approach to care may be appropriate. Options include intravesical lidocaine. Lidocaine is a local anesthetic that acts by blocking sensory nerve fibers in the bladder. Intravesical hyaluronic acid. Intravesical injection of botulinum toxin A or Botox. Intravesical dimethyl sulfoxide or DMSO. Adverse effects of DMSO or dimethyl sulfoxide include a garlic-like taste and odor on the breath and skin, and bladder spasm. Full eye examination is needed prior to starting treatment, and 6 monthly blood tests for renal, liver, and full blood counts are advised. This treatment may not be offered in all hospitals in the UK, as it is an unlicensed treatment that needs to be prescribed by a consultant with special expertise in this clinical field. For this reason, referral to a specialized center would be recommended. Intravesical heparin and intravesical chondroitin sulfate. Further treatment options. Further options should only be considered after referral to a pain clinic and discussion at a multidisciplinary team meeting. Cystoscopic fulguration and laser treatment and transurethral resection of lesions can be considered if Hanner lesions are identified at cystoscopy. Hanner lesions do not respond to oral treatments and need surgical management. They are usually diagnosed by cystoscopy with the appearance of a well-demarcated, reddish, mucosal lesions lacking in the normal capillary structure, which usually bleeds. Neuromodulation or nerve stimulation in the form of posterior tibial or sacral neuromodulation may be considered after conservative, oral, and/or intravesical treatments have failed in a multidisciplinary setting. Posterior tibial nerve stimulation or PTNS is likely to require a fine needle being inserted 5 cm cephalad from the medial malleolus and posterior to the margin of the tibia at the site of the posterior tibial nerve. The treatment regimen is usually weekly for 10 to 12 weeks. Sacral nerve modulation involves an initial test phase with insertion of a test lead tunneled under the skin, transmitted onto the nerve roots, exiting the S3 foramen, causing stimulation of the pelvic and pudendal nerves. The lead is connected to a stimulator, which is exchanged for a permanent implant if successful. This treatment should be carried out in centers with expertise at managing chronic pain in a multidisciplinary care setting. Oral cyclosporine A may be considered after conservative, other oral, intravesical, and neuromodulation treatments have failed. Patients treated with low-dose oral cyclosporine showed improvements in bladder capacity, voiding volumes, pain, and decreased urinary frequency. However, symptoms recurred with treatment cessation. Adverse effects include hypertension, gingival hyperplasia, and facial hair growth. Cystoscopy with or without hydrodistension may be considered if conservative and oral treatments have failed. Bladder rupture is a possible complication of prolonged distension of a diseased bladder, hence low-pressure distension is advised. Major surgery may be considered as last-line treatment in refractory bladder pain syndrome. Total cystectomy and urinary diversion in the form of supratrigonal cystectomy with bladder augmentation, bowel or supratrigonal cystectomy, and orthotopic neobladder formation will likely need intermittent self-catheterization, and patients must be aware of the likelihood of persistent pelvic and pouch pain post-surgery. Urinary diversion in the form of an ileal conduit with or without simple cystectomy will not require intermittent self-catheterization. This surgery is usually performed in specialist centers by a urologist. Treatments that are not recommended. Oral hydroxyzine does not appear to be an effective treatment for bladder pain syndrome. Oral pentosan polysulfate or PPS does not appear to be an effective treatment for bladder pain syndrome. Long-term antibiotics, intravesical resiniferatoxin, intravesical Bacillus calmette-guerin, high-pressure long-duration hydrodistension, and long-term oral glucocorticoids are therapies that are not recommended for bladder pain syndrome. Further management. Primary care. In primary care, a careful history should be taken, inquiring about type, duration, and location of pain, urinary symptoms, and quality of life. Primary care should also check that all conservative measures have been taken. A urine dipstick or midstream specimen of urine is recommended to rule out a urinary tract infection. An abdominal and vaginal examination may be performed to assess for tenderness, abdominal masses, and urinary retention. Patients should be commenced on first-line conservative treatments such as analgesia, stress relief, dietary modification, exercise and physical therapy, and if these fail to resolve or improve symptoms, a referral to secondary care should be considered. It is expected that these conservative measures may take between 3 and 6 months to improve symptoms. Referral to a urogynecologist or urologist with a special interest in bladder pain syndrome would be preferable rather than a general gynecologist when the main symptoms are pelvic pain and urinary in character. Secondary care. Patients who fail to respond to conservative treatment should be referred to secondary care. Patients should be referred to secondary care after 3 to 6 months of conservative management if symptoms persist. Multidisciplinary team, physiotherapist, pain team, and clinical psychologist. Referral to a physiotherapist should be considered as BPS symptoms may be improved with physical therapy. Consider referring patients with refractory BPS for psychological support or counseling if it is impacting on their quality of life or the patient requests a referral. Patients with refractory BPS should not be referred to a multidisciplinary team in order to explore alternative treatment options. Those patients who may benefit from neuromodulation should be referred to a multidisciplinary team before treatment is commenced. Support groups. Patients should be given written information about patient organizations that provide evidence-based information. Long-term management and prognosis. What should be the duration of follow-up? Patients should be followed up periodically in secondary care with consideration for shared care between the pain team and urogynecology until symptoms become controlled, and then they can be followed in primary care if required. Bladder pain syndrome and pregnancy. Women can be advised that the effect of pregnancy on the severity of BPS symptoms can be variable. BPS treatment options considered safe in pregnancy include oral amitriptyline and intravesical heparin. Although one course of dimethyl sulfoxide or DMSO may be used prior to pregnancy for symptom remission with good pregnancy outcomes, delivery at term, normal birth weight, and postnatal symptom control, DMSO is known to be teratogenic in animal studies. Amitriptyline has the lowest risk in pregnancy. Heparin is the safest intravesical treatment because it is unlikely to be absorbed from the bladder or to cross the placenta and is not excreted in breast milk. Sacral nerve stimulators should not be placed during pregnancy, and if already present, should be turned off for the duration of pregnancy as the effect on the fetus is unknown.